Review prostate MR cases online. Answer each case according to our structured pro forma answer page. And then get immediate feedback against a radical prostatectomy. 300 cases, track your progress, earn CME points. Visit mripro.io.
Wherever in the world you might be beaming in from today, good evening, good afternoon, or good morning, depending on where you're coming from. Do feel free to say hi and tell us where you're joining in from on the chat box or in the Q&A. And please feel free to use the Q&A throughout this 1 hour webinar. My name's Jeremy Grummett. I'm a urologist and an associate professor at Monash University in Melbourne here in Australia. I'm also co-founder of MRI Pro, which is our online training program for reading prostate MRI. Once again, today's webinar is brought to you by MRI Pro, but we're going to have a different take on prostate MRI today compared to the typical webinars. We're not going to look at any easy ones today. Instead, we're going to be focusing on all the tricky ones, where we went wrong, and we're going to discuss some tips and tricks to minimize error. So we've got a stellar panel joining us today. Before I introduce our panel, I do want to show you a very short video just to give you an idea of how the MRI Pro program works. So just bear with me while I share my screen. Just need to be able to share the screen, Alex. We might do that in just a moment. It looks like that function's being disabled for some reason. All right, we'll come back to that. I'd also like to thank Movember, who have been a great support to MRI Pro over the journey in getting this educational material to you around the world. So let me just try again in sharing the screen. All right, hopefully you can see this. I'm just going to play a very short video just so that you can see how MRI Pro works.
Review prostate MR cases online. Answer each case according to our structured pro forma answer page. And then get immediate feedback against a radical prostatectomy. 300 cases, track your progress, earn CME points. Visit mripro.io.
All right, and again, just to thank Movember for all of their contributions along the way. Before we introduce the panel, just a quick reminder that in addition to the individual subscriptions you can get to MRI Pro, there is also institutional licensing available. So if you think you or your colleagues might benefit from the 300 case program, just get online to MRI Pro at that website address there, support@mripro.io. All right, so we are thrilled to have 3 guest panelists join us for the webinar today, or tonight as it is here in Melbourne. We have radiologist Professor Valeria Panebianco, who is Professor of Urology at Sapienza, University of Rome. Valeria, thank you so much for joining us today. Valeria has been a huge contributor to prostate MRI and an educator in this space. It's really the ideal person to join us today to help us take us through the difficult prostate MRI, having authored a paper on pitfalls on prostate MRI. In fact, I'll just quickly show you that paper. I'll just get that up for you in just a moment. So I highly recommend having a look at this paper. It's published 3 years ago in Insights Imaging, and there are some fantastic images in this publication to help you with getting past those pitfalls. So thank you, Valeria, for sharing that. Very much looking forward to hearing your input on the cases that we've got today. We're also joined by urologist, Professor Mark Frydenberg. Mark's one of my colleagues here in Melbourne, Mark Emberton from UCL in London, UK. Mark is very well known to the urology community, needs no introduction, but is obviously very well known for all his work on imaging for prostate cancer, as well as for pioneering focal therapy in prostate cancer as well. And our final guest panelist is radiologist and nuclear medicine physician, Dr. Lisa Tarlinton from the SAN Hospital in Sydney. The two of us having just joined together on a panel a couple of days ago for the Royal Australasian College of Surgeons, ASM. Now, Lisa has expertise in prostate MRI as well as PSMA PET. And so we hope to have some time to have a look at some of the contributions that PSMA PET can also make to some of the more difficult MRIs as we go through the cases. And of course, we're also joined by our regular panelists, Associate Professor Richard O'Sullivan from Healthcare Imaging, and Dr. Andrew Ryan, tissue path specialist uropathology service provider here in Melbourne. Richard and Andrew have been our panelists all throughout this webinar series, and thank you very much for joining us once again. So let's get on to those cases as time is ticking. We'll start off, Richard, if you're happy to get going with the first case. And while you're setting that up, Richard, I'll just introduce the actual background clinical history. So case 1 today is a 68-year-old man who presented with an initial PSA of 9.3. And before we actually discuss these images, he had this MRI which was reported as negative. Now, his PSA then dropped down to 7.1, giving a PSA density of about 17%. So at that stage, we actually decided against proceeding to a biopsy and got him back 6 months later with a further PSA, but it actually popped back up again to 9.3. So he had a density then actually of 23%. So let's, before we go to the next clinical aspect of the history, let's go through this MRI. Richard, are you happy to take us through and highlight the...
Sure, this is how I set up the system. This is how we scan the patients. We do 3 plane T2s, a sagittal in the top left-hand corner, bottom left-hand corner axial T2 and a coronal T2. And then we do diffusion in 2 different planes. The ADC is in this the upper right-hand side. And the high B value, we run it at a B value of 1400 on the axials. And then we do the same again on the sagittals, the ADC here on the bottom left and the high B value on the right. And we give all the patients contrast as well. Just to make that a little bit easier to see, I'll just put the relevant images up.
Thank you.
So they're a bit larger. Oops. Just give me a sec to link all those. So the prostate volume is 40 cc in this patient. You can see as we go through the actual T2s, the top right-hand corner, this typical BPH appearance, nodules that are hyper-intense and hypo-intense, but all well-defined with some minor linear abnormal signal intensity throughout the peripheral zone on the T2 images. There's a little bit of rectal air obscuring the base on these pictures. You can see the rectal hair and the sagittals. But there's no focal area restricted diffusion. There's no, I always think I need to look at something that's black and white. So there's nothing that's black on the ADC and nothing that's bright on the high B value diffusion imaging. And the same as if we look on the sagittal high B value imaging in the top right-hand corner, there's nothing of increase in intensity there. And then if we look at the fused color images, we can see there's no focal enhancement. So I reported this out as a PARADS 2 lesion, no index lesion.
Okay. Just having a look at those, Valeria, is there anything that jumps out at you at all?
I confirm the presence of artifact due to the air in the rectum.
Yes.
So there is a big BPH. No more. I agree. Yep.
So you make the comment about a lot about gas being in the rectum. We might come back to that later on. Basically,
Jeremy, sorry, in this case, generally, I would suggest to repeat the sequence when the artifact is evident. Just a suggestion, no more.
No, absolutely. So, Richard, do you want to comment on that? Because I know that sometimes if you're not happy, if there's too much gas in the rectum, you'll actually get patients back. Is that correct?
Oh, yeah, definitely. We rely on when we've got any artifact, we rely on the post-contrast more heavily. This is an older study. It's now 3 or 4 years old, and we've been giving patients bowel preparation now for probably since about then. So our callback rate has dropped substantially as a result of that, and we hardly ever call anybody back now that we give them a bowel preparation.
Yep. Okay. So,
Mark? Yeah, it'd be interested in the radiologist. So, accept that this imperfect study because of rectal air, but is there some suspicion in the right anterior horn? there's a bit of low T. There's a bit of low T2 signal, a very, very soft signal on the diffusion sequences, just about 9 o'clock. I just wondered whether anybody thought there was.
At the
See the right anterior horn there compared to the left in the mid gland.
I'm just going through
on the high B value there, Mark.
Yeah, you can see.
Yeah,
you can just see a little something. You know, it's and that just, if we are going to watch this, we might watch that very closely.
Yeah. So, just on that, or moving on rather, despite that negative MRI, I went ahead and did a biopsy because this guy's PSA density was pretty high. It was actually 23%. He doesn't have a particularly enlarged prostate. Andrew, perhaps you could get up the biopsy results. So when we do biopsies, it's a routine template biopsy, transperineally, but despite, and we'll come back to the MRI in a moment, but despite the negative MRI report, I did do some targeted cores, not where you were saying, Mark, but actually posteriorly in the midline. We'll come back to the MRI in a moment, but this is what the biopsy showed.
Yeah, so we've got high-grade disease, 4+5, grade group 5, up to 12 millimetres in the left mid, smaller volume in the right mid, and then, as you said, the target has also got quite high volume, 9 millimetre in 4 of the cores, also demonstrating perineural and extraprostatic extension.
So that was a very nasty surprise. If we could go back to the MRI, perhaps, and just see if we can see where that is actually occurring. Richard, can you do that?
I have a question for the pathologist.
Yes,
is there the typical pattern, cribriform pattern?
That's a good question. I haven't gone back and reviewed, but certainly at 4+5, I'm expecting to see, well, actually, I can't probably answer your question about cribriform, whether there's cribriform. I'd have to review the actual slides, but certainly high grade and not what was expected. But I do kind of know where you're getting to, and that whether or not it's whether or not we're not seeing it because of the pattern of the actual prostate cancer.
Richard?
I can't, in retrospect, I can't see anything here. I think it is worth a little bit of a discussion. We basically find it's abnormal, we measure cell density essentially. I think that's what you're getting to, isn't it, Andrew?
Yep. So, Richard, if you can just scroll a little bit closer towards the apex, because
on the T2s,
mainly on the high Bs and the ADC MAC actually, and you'll see just on the transverse though. Anyway, we should be able to get that up, and just scrolling back through. Stop there. All right, see that? So right in the middle, towards the posterior aspect of, not on the T2s, but on the DWIs, Richard, there's brighter intensity on the high B value and a low intensity on the ADC map, right in the midline, but towards the posterior transition zone. So it's a very unusual spot, and this is why I think this is so tricky. Now, I obviously fluked it in thinking, well, maybe there's something going on there, but that was called negative. So, Lisa, you asked the question on the chat there, did I do a targeted biopsy because of the gas artifact? I actually didn't. I did the targeted biopsy because I thought I saw something in the midline here. So again, this was very lucky. But what would you say now, Richard, now that we're focusing on it? It's still...
I think it's a true negative.
Yeah, right.
This is the Viru here, Viru Montanum, and there's no real correlate. There's no homogeneous decrease in intensity, Jason. That I've just measured the ADC on our system, comes out about 1100, which is not really in the abnormal range for me to be able to go from a PIRADS 2 to a PIRADS 3, which would be the most I would call it there.
Okay.
And we know, don't we, that posterior TZ tumours are very rare. I mean, TZ tissue is young tissue. This chap isn't very old. there isn't much time for cancers to develop. And posterior TZ tumors, you know, when we do see tumors in the TZ, they tend to be anterior. So this is becoming a very, very unusual case. There aren't many Gleason 4+5s that are non-visible. This is you know, very, very, very unusual. Posterior TZ tumors are extremely rare. I'd need some convincing. And tumors around the urethra, particularly, because that's where TZ growth occurs. So you've got very, very young tissue there, which has hardly had time to develop a cancer, unless there's been some extraordinary mutation that allows a very rapid growth of cancer.
Lisa,
I agree completely. I think most of the transition tumors are anterior or anterolateral at worst.
Lisa, have you got any comments on this one?
Richard, sorry, the lesion with the 12 millimeter was on the left side or on the right side in peripheral zone. Would you show again the pathologist report, please?
Yeah, so
it might be helpful, Andrew, to show the whole mount. So this patient proceeded to a radical prostatectomy.
Okay.
So that, I think that'll help everybody see what the actual story is.
That was the original, Valeria. That was left mid. So that was the 12 millimeter.
Left mid, yes, 12 millimeter of 2 cores.
Yeah.
On the left side.
Yeah,
So,
and I'm not sure where was your target more on the left or right,
Very strange because there is no diffusion. There is no diffusion. The lesion is from the peripheral zone. I understood.
Yeah. So
okay, very strange. Maybe there is a big component of pattern, typical pattern, cribriform pattern form.
Yeah, so this is the whole mount. These are the reconstructions you can.
You know, there is no restriction due to the movement of into vacuoles typical of the cribriform pattern, as you know. Okay, maybe this is my interpretation.
So these are quadrants.
You agree?
These are quadrants reconstructed to show the transverse sections of the prostate, going from base or apex up to base, with additional parasagittal sections of the base laid out from midline through to lateral, and similarly at the apex. So you can see quite a large volume tumour, certainly involving the peripheral zone or the posterior aspect of the prostate up towards the base. It has got a more central distribution in these lower 2 transverse sections, but certainly involving the peripheral zone in these apical sections where this is posterior and this is anterior. And the summary, this is the structured report, ended up being 5+4. So it's certainly a very high-grade tumour. It's got extraprostatic extension at the apex and the base, bilateral sentinel vesicle involvement. The other thing was you did 23 nodes, all negative as well.
That's good.
Lisa, did you want to make a comment on this?
Yeah, I just wonder whether it's one of those tumours that started in the central zone and has travelled down the ejaculatory duct centrally in the midline. Just seeing it go right from the base, and when you have measured that 12 millimeter core of tumour, I wonder whether that's in the craniocaudal axis, and I suspect it might be travelling down the ejaculatory ducts there.
The only thing against that, Lisa, is that we sometimes do see those. We certainly see that as a phenomena, and I actually wonder whether or not they're starting at the verimontanum and going up towards the base, and they shoot out through the top of the seminal vesicles. Whereas this has got quite a lot of bulk of tumour in the peripheral zone down towards the apex, which in theory shouldn't be able to get there from the central zone, unless it's direct invasion and then growth.
And so, Richard, you're basically saying, having reread it now, having seen the whole mountain going back over the images, you would still call it a PIRADS 2 based on PIRADS version 2.1.
I think it's a true false negative. I think this does happen. It's rare. And I think this is where we have to be driven by the PSA density, the clinical story, all that sort of to put you in a situation of biopsy, because that's really MR's strength, is to give you a target for a biopsy. And then in the end, you have to make a decision whether it's answering your question. If it's not answering your question, you still need to biopsy. I think that's the bottom line for me.
Yep. Okay. Any other comments on this case before we move to?
I think the only clue was the PSA density, wasn't it? So you had a PSA that was falling after the first. But we often see that, don't we, as a kind of regression to the mean. People are referred with a high PSA. Next time you do it, it's lower. That shouldn't reassure us, because that happens in the majority of patients. But that persistent high PSA density was the only clue that there was something amiss. And you were very clever to biopsy him. I probably would have waited, actually. I would have gone on, because the MRI was so reassuring. But you did the right thing.
Here's the bad news, though, Mark, and I appreciate that. But remember, I did wait 6 months because I didn't biopsy initially because of a negative MRI. So remember, we're really focusing today on some of the pitfalls of MRI, even though it's a wonderful test normally. But in the workup, once I'd done the biopsy and in the workup for surgery, we got a PSMA PET scan. And you can, again, see, I hope, on this image here, below the radiotracer accumulating in the bladder, the very avid portion right in the middle of the prostate here, but you can also see 3 positive lymph nodes. Now, I know this is obviously not standard of care in terms of proceeding with radical prostatectomy, but remember also that these nodes are only visible on PSMA PET, so we don't actually have any evidence-based guidelines to say what we should be doing. And without PET, staging would have been negative. So he did have that prostatectomy, as you've seen the whole mount on, but as Andrew said, there were no lymph nodes positive despite removing 23. And so he went on to have stereotactic radiotherapy to those nodes and has required hormone therapy as well, unfortunately. But I guess it just shows you that, had I actually gone to biopsy 6 months earlier, would there have been a difference? We'll never know. But if I had done a PSMA PET at the earliest or at the outset, then I might have done a biopsy right at the upfront. So Lisa, have you got any comments on that?
Yeah, look, I know it's not standard of care, and I don't want to be prescriptive about what should be done. We're very lucky here in Australia, and when we have a negative MRI but a high clinical index of suspicion of prostate cancer, then we would do a lot of the time a PSMA PET prior to biopsy and fuse it with the MRI and use that to guide biopsy. There's no MBS rebate, obviously, but we're very lucky that we have some funding privately, and we have a lot of patients that pay out of pocket. And these are generally these difficult MRI occult cases.
Yep. All right, we better keep moving because time is ticking. Richard, are you happy to get case 2 images up, and I'll...
Jeremy, a lot of us are doing less examination now because we rely on MRI. Yep. So did you examine this man? Did he have a DRE?
Yes, he did. And
he did, and you couldn't feel that lesion at the base? Okay.
No.
Yeah.
No,
so that's an interesting change, isn't it? We're relying on MRI, so we don't examine patients in the way that we did. I mean, DRE is a terrible test in terms of specificity and sensitivity. But sometimes you would have thought that you could feel this either at the apex or the base. And maybe that's something to think about.
Yep. Yeah, no, agree.
Jeremy, I have 2 comments.
Yes.
So the first one, the tumor from the central zone is rare, okay? And we don't have experience about the behavior on MRI. And I would like to underline my suggestion for Kriegel-Von Pater. I'm sorry. So the second one for Lisa, okay. I would like to classify the patient in the risk group. For you, Lisa, this patient is intermediate or high risk based on PSA, total PSA density, age, and so on. Why do you suggest PSMA in this case? When MRI is negative?
I guess that, you know, this gentleman is only reasonably young from what I understand. And there's a high clinical index of suspicion, and he's got a very high PSAD. And from our experience, we know that there's a subset of men where PSMA really benefits. And I think that if you're going to make a difference, and then this is particularly the type, the young man with a high clinical index of suspicion, that this is a great case where you would do it.
Of a big adenoma. Also, when you see BPH, enlargement of adenoma, do you suggest the PSMA? In any case, when the PSA density is high, okay.
Yeah, I think the potential advantage, Valeria, is that even though you go on to do a biopsy when the PSA density is high and you're still suspicious, obviously if there's no target, then you could still potentially miss a cancer unless you're doing a saturation biopsy. But if I had done a PSMA PET up front and there was a hotspot, I would have gone straight ahead and done a targeted biopsy of that area and got it. Now we should move on to the next case. Richard, if you're happy, you've got case 2 up there. So this is a 61-year-old gentleman, PSA of 5.0. And Richard, perhaps if you go through the MRI, which shows a couple of abnormalities.
I'll just show the most obvious abnormality to start with. Again, it's a relatively small prostate volume of 40 cc. And there's a dominant lesion here that measures 2 centimeters in size at the left base. It's homogeneous decrease density on T2 images, but does demonstrate restricted diffusion. You can see on the sagittal high B value, it's very bright on the high B value, and it's dark on the T2, on the ADC. This is one of those ones that PIRADS 2 and PIRADS 2.1 are different on. On PIRADS 2, I'd call this I'd call it PIRADS 2, and now because it's got restricted diffusion, we have to go to PIRADS 3. But you will see that it's very well defined at the margins on all the pictures here, on the coronals and on the sagittal. So I think it probably is a true PIRADS 2 with restricted diffusion. So we'll just move on from that part of it to the other part of it.
Yep.
So as we go down from base towards the apex, there is a second lesion here that we do see on the T2 images in the posterolateral peripheral zone at the left apex. It measures just on 0.5 centimeters in size. It's dark on the T2 images, and it's dark on the ADC in the bottom left-hand corner, and it's bright on the high B value. We struggle to see it on the sagittal T2 images. And if I put the sagittal high B value up there, we can see it again here, and we'll put the ADC next to it. We can see here it's dark on ADC and bright on high B value here at the. So I think that's a PIRADS 4 measuring 0.6 centimeters in size.
Any comments from our radiologists, Valeria or Lisa, so far?
Just scroll down again the high B value sequence, please.
The high B value?
Yes.
The axial?
Axial.
Go back to screen shares.
On axial plane, yes.
Yeah, maybe just keep your images up for now, Richard.
You're talking about here? Here's the high B, here, this is the T2, and here's the ADC.
Up and down, please, Richard. Okay.
I beg your pardon?
From the apex to the.
I'll link them again, so we'll go through them all together. That's probably the easiest thing
Slice
to
per
do.
slice, slice per slice, please.
So we'll just go, here we are at the apex, and we'll just scroll towards the base.
Would you scroll, please, at middle gland, and then at base? So this is the apex.
No, we're at the base now.
Please.
We're at the base now. There's a seminal vesicles there. Seminal vesicles here. So we're at the base, and now I'm going from the base, that's that BPH nodule, from the base towards, that's the mid-prostate, and now we're getting towards the apex.
Okay.
Okay.
Happy?
In any
Lisa?
case, I confirm Pirates 4 on the left apex.
Yes, here.
And I suggest also to the biopsy at the level of BPH nodule. My suggestion is Pirates 3, no more, and the stromal BPH.
Yes, I think that's what you did, isn't it, Jeremy?
Yeah, yep, we'll come to that in just a moment. Lisa, any comments from you?
No, I just scroll down to the extreme apex again on the T2. So just partial voluming there. There's no restricted diffusion anterior to the urethra. I'm presuming that's just partial voluming through a BPH nodule. Yeah, it's only on one slice. Yeah.
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 So,
And the here anteriorly.
so with the PIRADS 4 and 3, 2 lesions, this patient went on to have a transperineal biopsy with targeting of those 2 lesions. Andrew, have you got that biopsy result there?
So that's got a left anterior base target and left apex peripheral zone target. It's got very small volume, low-grade disease, grade group 1, 0.7 and 1 millimetre in the target apex and right posterior.
So essentially insignificant cancer has been found, tiny volumes of what you might expect anyway. I took on this occasion 6 cores from each of those targets. Mark, question for you. When you do targeted biopsies, how do you do them and how many cores?
As you know, every patient asks you before you do it, how many cores you're going to take. And I say, I don't know. And you know, sometimes you get a feel that you're getting good tissue, and the nurse is sitting on my shoulder telling me that I'm getting a good core. So I want decent cores. And if I'm getting good cores and I'm targeting, I want to get plenty of direct shots and a couple of shots outside the target. So it's actually quite a lot. And I believe that you're better off sampling high probability areas rather than sampling low probability areas, which would be non-targeting. And so it's always more than 6, and sometimes it's up to 10. It depends. The apex there, you know, you haven't got much space. It should be fairly easy to target that left peripheral zone at the height of the urethra. So you've got lots of lots of kind of anatomical fiducial markers to help you. Obviously, the lesion is small, but I think that would be adequately sampled. Obviously, the anterior lesion, you'd only need a couple of cores. You would get good, I'm sure you'd get really good tissue from, and you'd know your needle was inside that because you could see it on ultrasound. Yeah. Exactly.
And that's my practice too, is to really pepper the lesions that are on the MRI. Doesn't really matter how many times you do it, as long as it's a lot, I think, because you want to take into account needle deviation and all those other potential errors can come into the picture. Totally agree with this particular patient. Clearly the larger lesion is just a BPH nodule, and that was obviously targeted as benign. But I guess because that PIRADS 4 lesion is pretty small, even though I peppered it with 6 cores, you know, there is still a chance that perhaps there's something lurking. Valeria, is this biopsy result what you would expect from seeing that MRI? With us?
Type of biopsy. How many cores in the target area?
6.
6.
6 cores from each target area.
Which technique used? Fusion,
Cognitive. It was
cognitive, or what?
cognitive fusion or co-registration.
Maybe the problem is the cognitive approach, because the fusion biopsy or inboard biopsy should be better when we perform a biopsy in the target area, especially when the lesion is small.
Yep.
As in this case. So, and in our experience, we perform a target biopsy in a double way, fusion biopsy or target or inboard biopsy.
Right. Okay. So you're doing inboard
biopsy in this case, because the lesion is located in the apex, first of all, and also because the lesion is very small.
Mark, you
lower than 8 millimeter in diameter.
I think, I mean,
maybe in this case the diameter is very very small. So, and we have lower than 0.5 cc. So, insignificant cancer, also in the apex. What do you think? Active surveillance in this case?
Correct. Well, that's what we did. Sorry to interrupt, Mark. We put this patient on active surveillance because even though there was a PIRADS 4 lesion, you know, we really haven't found any significant cancer. So 6 months down the track, his PSA is basically the same. Mark, what were you going to?
Yeah, I think we'd all continue to monitor a PIRADS 4 lesion despite you know, if it shows 1 millimeter 3+3 or normal tissue. Yeah. You know, the one thing about biopsy that we can't control is the tissue capture. So it's the Z plane, and you know, this is a tiny lesion, and you could hit it every single time on target, but you cannot be sure that you captured that lesion in the Z plane. So we would watch it. In relation to your discussion with Valeria, my advice is to do what you're good at. The current evidence doesn't really show any benefit. You know, good cognitive seems to be as good as fusion, and fusion has its problems. You know, and you need really good MRI, really good contouring. You know, and then really knowing your software. And at the extreme apex, doesn't matter how good the fusion. Often you can't get a perfect fit at the apex. So I probably would have done what you've done and just dropped the fusion for that and used the anatomy, because you know exactly where it is on that MRI. It's cornered, isn't it? Right at the apex. There's not much tissue. It's a bit of peripheral zone just to the left of the urethra at the extreme apex, and that's what you go for.
And so leading on from that, Mark, what is your current practice of how you do active surveillance?
Well, I think a loaded question. So we've largely dropped biopsy now, and are using imaging, and because we don't biopsy the negative scan, despite our first case, which is very unusual and actually does make you rethink that a little bit. Our surveillance is largely about lesion surveillance. So if you have a negative biopsy, we obviously monitor the PSA. And maybe do a 3-year interval MRI or something. We're trying to work that out now. And so most surveillance now is lesions. And as you know, we've recently published on that. And lesions do progress. And lesions do change the behavior in terms of the likelihood of failing active surveillance. So I'm very, very comfortable about microfocal Gleason 3+3 with a negative MRI. I think those very, very few of those men progress. The lesions you have to watch. And in the paper we published, Caroline Moore led on, there's a kind of chart of how long different combinations of lesional presence and underlying Gleason score tend to last on surveillance. Obviously, if you've got, it's just like a diagnosis, if you've got disparate findings, you've got a rising PSA and a normal MRI, you have a low threshold for going for biopsy in exactly the same way as you did for the first case. And so one has to be careful and safe. But the patients seem to like it. They like it, and I think we've largely been able to avoid the sequential planned biopsies, which I think most people are trying to get away from.
Thanks, Mark. Question from the audience just quickly before we move to the next case. Would you, for the radiologist, would you upstage to PIRADS 4 in the area of marked restriction diffusion? If the area of marked restriction diffusion is lentiform or irregular shape within the BPH nodule. So that was given PIRADS 3.
I'll go first if you like.
Okay, Richard, yep.
I think the margin's the most important part of it. And my sort of rule is, if I can see a black line that goes around this lesion in 2 planes on T2, I would never call it a PIRADS 4. But the shape is also important, and as we've heard earlier, the location is also important. But my most important would be the margin.
Yeah. Lisa?
Lisa?
You're on mute, Lisa.
I agree. I know what you're saying with the high B value in that BPH nodule, but I do think it's well demarcated, and I'd probably call that a PIRADS 2 at the left base. I probably, even with the new PIRADS 2.1, I don't think I'd be upgrading that one.
All right, let's move on to the next case, number 3. Now, this is a 62-year-old man with a PSA of 4.0. Just while you're getting that up, Richard.
Yeah, I've got that up. That's okay.
It's not showing yet.
Okay, we'll go to shares.
So now his MRI was reported as negative, but we repeated the PSA. It was still slightly elevated, only 4.4, but a bit of a suspicious free to total PSA ratio of only 11%. So again, based on that suspicion, even though he had a negative MRI, I went ahead and did a transperineal biopsy, which we'll come to shortly. But let's have a look at the MRI, Richard.
So I've just put I've linked these 3 together, the T2s on the left, the ADC in the middle, and the high B value on the right. And we'll just scroll from base to apex. Typical BPH here, relatively homogeneous decreased signal intensity throughout the peripheral zone, which is always a little bit of a concern. But no real focal restricted diffusion. It's a little bit dark here. It's a little bit dark higher up, but it gets a little bit bright. But the ADC never gets below about 1200 on our system. So I can't see a focal lesion on this patient. I'd call this a PIRADS 2.
All right. So Andrew, do you have the biopsy there, and then we'll come back.
So these are labelled as per your POTS rather than anatomical sites, but you know what you took. But we've got adenocarcinoma, grade group 2, all very small foci, 1, 2, and 0.5 millimeters in the, I think it's labelled RA, RB, and RC.
Yeah, they're on the right side. So no, this was this was when we were using sort of coding for our labeling, so which we don't have. But the bottom line is that there was a smattering of tiny volume, just clinically significant cancer in terms of there being a very small percentage of Gleason pattern 4. But you can see that as you say, the longest core there of it is 2 millimeters, and so this patient went on active surveillance. As a result of that, and then over the ensuing couple of years, his PSA went up to 6.2, giving a density of 21%. So I was getting a little bit itchy at this stage. Remember, he was 62 years old when we first biopsied him, and so this is where we decided to get a PSMA PET as, I guess, something of a tiebreaker. Now, again, this is not evidence-based practice, but because it's freely available, that's what we did. So I'll just quickly show you what that PSMA PET looked like.
while you're getting that up, Jeremy, I've seen noted multiple questions about how you do your transperineal biopsies and whether it's general anaesthetic, local anaesthetic, especially if you're peppering target areas with large numbers of cores.
Yeah. Well, in our own practice, we've been a little bit spoilt in Australia. It's been very easy to do transperineal biopsy under local anaesthetic, under general anaesthetic, because we haven't had such enormous pressure on our operating theatres, and we have, pretty healthy private practice system as well. So we have been doing it, myself have been doing it under general. However, now that transperineal biopsy has been well shown to be quite achievable under local anaesthetic, we're certainly in the public system, we're turning to that, and I suspect will extend throughout all of our practice over time. But what about you, Mark? Are you doing it under local or general or sedation?
We do both. So in fact, all three. So local and sedation on the NHS. I think you get a good feel about whether the patient's going to tolerate it under local when you speak to them, and then obviously general. I mean, if you've got the right setup and good anesthesiology, it can work very, very quickly. Patients love it because they don't feel anything. I think it makes the whole thing a little bit easier. We haven't proven that, but you'd think if millimeters matter, having the patient completely relaxed so that you can do targeting in the way that you want to, you'd think would make an effort. I think the other thing, if you're going for a very anterior lesion and a big prostate, then go for GA. So again, personalize the decision. I don't think it's a one-size-fits-all approach. Some patients prefer local, they want to avoid a general, that's fine. But look at the prostate, look at the lesion, and make a kind of shared decision on it.
Yes. I think one of the, as I'm sure you know yourself, Mark, one of the biggest drawbacks of more widespread uptake to transperineal biopsy has been this obstacle of, having to get them into hospital and do them under GA, especially in the really high volume centres. But at least for the sake of progressing transperineal biopsy to become standard practice, that obstacle seems to have been removed with the recent studies, which is encouraging.
I think the prostate biopsy is as important as a brain biopsy, and so I'm not very tolerant of people that say that they want to do it in the back office, in 2 minutes, like we used to. Yes. I think it's the most important event in the whole prostate cancer journey, and if you get it wrong, as we've discussed, then obviously the patient lives with that forever. So I think we should really strive and lobby for optimal setup. That's great MRI, fusion if you want it, and an appropriate place in which to do it.
Yes, and perhaps arguably even more important with the prospect of potential focal therapy, where your accuracy is absolutely critical. Yeah. So this is the PSMA PET that we obtained on this patient, and the red circle is showing an avid lesion up the right base of the prostate. So you can see the bladder with radiotracer in it, but a very hot lesion there at the right base. So I'll stop sharing. And I wonder whether we could go back to the MRI at this stage, now that we've seen what the PSMA PET showed. Richard, are you happy to show that again?
I think we're back on here, are we?
Yep.
I'm just linking them. So you can see on the actual T2s, there is some rectal layer, a bit like the first case. So the only bit that looks a little bit abnormal is here at the right base, but it is obscured on the ADC and the high B value. And if we go to the sagittal high B value again, it's obscured again. This is a air-related artifact. That curvy linear bright signal is very typical of artifactual. So that would be the only area that I would be concerned about.
Right.
And I would go back to the colour. Yeah. And there is just a hint of enhancement here at the right base on the DCE. Yeah. So I think the DCE is extremely useful in patients who've got rectal air. Mm-hmm. So that's the closest I can get to a correlate, which measures.
So would you? Yep, go on.
Sorry.
So would you do anything differently, knowing now what the PSMA PET has shown?
I don't agree. there are no
Okay.
focal changes in this peripheral zone. There are no focal changes. So in this case, I suggest to repeat the examination after 3 months after inflammatory therapy, and then targeted biopsy in the suspected area. Because the general changes are referred to inflammatory changes in this case. So the lesion has 1-2 millimeter in diameter. So the majority of the hypointensity of the restriction is diffuse and consistent with inflammatory changes.
Okay, well,
so suggest please to the patient to repeat examination after 3 months, after inflammatory therapy, or adding also antibiotic.
Okay, well, as you saw a moment ago, Valeria, we instead got a PSMA PET simply because it's available, and we kind of used it as a tiebreaker to determine whether we should continue on active surveillance or not. And we went ahead with surgery. And Andrew, if you're happy to show the prostatectomy specimen there.
So again, this is a reconstruction. You can see the quadrant sections, transverse sections and parasagittal sections of base and apex. And there is a bulky tumour on the right-hand side, mid-zone into the apex, but predominantly mid-zone up into the right seminal vesicle with extra prostatic extension. That's 4+3, graded as 4+3, 60%. And as I said, with extra prostatic extension, but negative margins.
Mm. So it's, you know, it's pretty interesting. It was
That's
very challenging to pick that up.
Perfect. That's why the patient should be performed targeted biopsy after inflammatory therapy in order to do the targeted biopsy in the specific area.
Yeah. Okay. Mark, have you got any comments about this case?
I mean, is this true progression? I mean, I think your biopsies of the right peripheral zone would have been, your original ones would have been good, I think. Yeah. I mean, this lesion should have been well sampled in your extensive biopsies.
It should have been.
There was plenty of peripheral zone there. I'm amazed, you know, so, you know, this might be true progression. What was the interval between your original diagnosis and the prostatectomy?
2 years.
Oh yeah, so it could be, and he's just unlucky. You know, he's one of the true progressors. You know, we don't see many of them actually. Most of them are, I think, are reclassification. But I think he had very good biopsies then. Your peripheral zone on the right would have been very well sampled, and that's what we do active surveillance for, actually, isn't it? It's delayed selective intervention. And some men will progress. The challenge is to pick them up early enough, and it looks like you did.
Well,
hopefully.
Well,
okay,
so
okay, next slide. Okay.
Could I just add?
Go on, Andrew.
We always talk about this as well. These are small volumes. The predictability or the accuracy of the percentage pattern 4 in these smaller foci is can be challenged.
Yeah.
You know, so it may well be that the tumor was very small and well sampled, and it was very small and has progressed, or it may well be that it was just poorly sampled in the first instance.
We don't have the MRI from 2 years ago, do we? Or when he was first went on active surveillance?
That's what it was.
What it was. We didn't have the second. Right. Okay.
Didn't have a second one.
This is just always suspicious when you've got small foci. This means that I've seen 1 or 2 diffuse glands being obliged to call some pattern 4, but when you've only got 0.5 millimeter of tumor, that's really, you know, spanning just the width of the core. So you could easily be assessing 10 or 15 glands there, and 2 of them are fused.
But I'm reassured that from that right peripheral zone, you had good core lengths. Yeah, you know, all above 10 millimeters. Yeah, you know, there were good chunks of tissue being looked at.
True.
Yeah. Well, the other thing that you can sometimes tell from, you know, if we have lots of, if there's been a single core and it's 2, 3, 6, and 3, then you've got fragmented chords. It often means that it's very thready chords, but these have all held together really well, so they're good chords.
And just to conclude this case, 3 years post-op, his PSA has risen very slowly, but is now 0.25. We got a follow-up PSMA PET scan, which was negative. Would you order an MRI in this case in the post-prostatectomy setting with a PSA of 0.25 and a negative PSMA PET, Lisa?
Of course.
It's funny you should say that, Jeremy, because I had a case that's still on the list to be reported, I think from Thursday, where a gentleman came to us with a rising PSA post-prostatectomy, but it was now quite high. I think it was closer to 2. And he'd had 2 PSMA PETs at outside institutions. And the first one was a gallium-68 PSMA PET with diagnostic CT. The PET was read by a nuke med physician, and the CT was read quickly and independently by a radiologist. PSA continued to rise, and he had a second PSMA PET in December last year at an institution where no diagnostic CT was done with the PET. And he had another, and it was gallium-68 again, and again, no cause for biochemical recurrence was seen. He then came to us at the end of March for a third PSMA PET, and the referrer asked us to do a 1007 PET so we could assess the anastomosis, because we know 1007 is less renally excreted. And we did that, and luckily this man actually had minimal renal excretion, and we got a good look at the anastomosis, and there was no abnormal PSMA uptake.
Mm-hmm.
However, on the diagnostic CT, I saw a very subtle hint of contrast enhancement at the anastomosis, and we went and did an MRI of the pelvis post-prostatectomy, and we found a non-PSMA avid local recurrence of the anastomosis. So look, PET is very helpful. 1007 has some benefits in the anastomosis, but the benign bone uptake with 107 drives me mad. But MRI, and particularly the DCE sequence post-prostatectomy, is very helpful.
Yeah, exactly. So I just wanted to highlight that point. The DCE is where it really comes into its own, isn't it? In the post-prostatectomy setting, perhaps less useful, obviously upfront, but still useful.
May add a comment about MRI. Okay. So recently has been published a new scoring, PIRR, in order to report recurrence, local recurrence after radiation therapy and radical prostatectomy. And it was a consensus, international consensus from the panel of experts. And we suggested to perform, in case of low risk and in some cases of intermediate risk, MRI, only MRI when the PSA is low. As you can see in this case, 0.2, as you know, is the biochemical recurrence, and MRI may distinguish also fibrotic tissue from the recurrence and other changes. So that's why MRI should be suggested in this typical case.
Even at a PSA as low as 0.2?
Yes.
Yep.
Yes.
Okay. Richard, any comments on that?
For both aims, to exclude the recurrence or to confirm the recurrence.
I would say, sorry.
And then, of course, PSMA when the patient is classified in intermediate or high risk grouping, according to the new AIU classifications. So please give a look to PIRR new scoring for reporting recurrence after radiation therapy and radical prostatectomy.
Great, thank you, Valeria, for that tip. Richard?
No, I would say we can be helped by the clinicians here. Local recurrence is usually slowly progressive, slow rise in PSA over months to a year or two. Often the patient had a positive margin at original surgery. There's 2 types of local recurrence, as I see it. The ones in the midline that are at the true anastomosis that is hardly ever seen on PSMA PET, and the ones at the seminal vesicles, which is typically seen on both studies.
Mm-hmm. Yep. Okay. Now, just to finish off, Lisa, are you happy to take us through a single case rather quickly, if possible, just looking at the time, just to, again, demonstrate how PSMA PET can sometimes be useful. Bearing in mind, I know that most of the audience may not have easy access to PSMA PET, but it's just interesting in the setting of the difficult MRI.
Okay, can you see my screen?
Yep.
Well, look,
Yep.
I'll be a little bit controversial here because, and I got in a little bit of trouble at RACS for suggesting PSMA PET in active surveillance, but, you know, we do it in a lot of cases and we found it incredibly helpful, you know, as it's not standard of care, but it has been helpful, particularly with us with men during COVID. And this is an example of a man who I think who if he got a PSMA PET at the time of diagnosis and starting active surveillance may have had a very different outcome. And I guess the red flags, this is a 47-year-old man who 2 years ago was diagnosed with 3+3 and was placed on active surveillance. Now, this was at an outside institution and he did not have an MRI prostate or a PSMA PET at the time of diagnosis. And then 2 years later, he came to see a urologist at our hospital. His PSA was rising, 6.2, and so he had an MRI prostate. And this was reported as PIREDS 2 changes, and I will show you that. His PSA continued to rise, and so he had a repeat biopsy 5 months after the MRI, and he was found to have high volume Gleason 5+4=9 disease, the age of 47. And so he was then sent for the week before Christmas for a PSMA PET with us, and there were 2 questions asked by the referrer. Firstly, to stage this young man with high-grade disease, and also why did we miss such a high-volume tumour on the MRI? And so if I scroll through the MRI, starting at the base, we can see I haven't included all of the seminal vesicles, but as we scroll through, we see that the central zones look symmetric. There's these sort of smudgy, just very mildly low T2 signal changes in the peripheral zones. There's no homogeneous or lenticular low T2 signal in the transition zone. And if we scroll right down to the apex, there's nothing really of note. Did anyone see anything in the gland on T2 that was concerning so far? So looking at the diffusion, now this was performed in 2018 before PIREDS 2.1, and we can see we have our B1400, our B2000, our ADC and our DCE, and we can see that the median lobe has quite pronounced restricted diffusion and quite confluent contrast enhancement. Now in 2018 with 2.0, there's no abnormality on the T2 in the transition zone, so this would be a PIREDS 2. Now we could upgrade it to a 3 based on size of diffusion. And I think what the key point is here is the DCE is not only is it very high, but you can see that it's very homogeneous and confluent, and it's lacking that popcorn appearance, more broken up appearance of contrast enhancement in the remainder of the transition zone. But we often do see this in the median lobe. We often do see significant restricted diffusion and contrast enhancement. So it's a difficult one. So that's his MRI. I'm not sure, Richard, if you'd agree with that. And if you find that there's often quite pronounced restricted diffusion in the median lobe.
I think that's common. I agree. I was just wondering about the high beat values there in the mid prostate correspond to where the, perhaps on that picture, the correspond there to the contrast. I think contrast enhancement is very useful in the transition zone as well.
Yes.
It's not confined. It's best at the peripheral zone, but it's also useful in the transition zone.
I agree. And the one thing that PET MRIs taught us is if you're going to actually spend the time and money to do contrast, then actually use it to its full utility. And I initially used to use it to upscore my PIREDS lesions. But then I realized when we had MRI occult tumor that often when it was PSMA and an MR occult, if you look back in hindsight, there is a confluent DC abnormality, and we've got quite a few cases like that. And Jeremy, that case where you showed the PSMA avidity of that right base, I saw that T2 lesion when you were scrolling through, and our PET MRI learning would be to go back and look at the DCE in that right central zone, because that's where we're missing the tumours on MRI that PET are finding is in the central zone. So if we look at the PET MRI now, so I use software fusion, and it just came out of a necessity in that I found cognitive fusion very easy in the AP plane, but I found PET and MRI fusion cognitively very difficult in the craniocaudal axis. So I had a free software and I used it and I tinkered, and I got it pretty quick now. It only takes me 5 minutes. And as we scroll through on the PET MRI, you can see that this is a very PSMA avid tumor. And I send this little movie to PACS, but I also deconstruct the PET MRI because the PSMA avid tumors are so bright that sometimes even if you window them, it's very difficult to see the lesion behind. And you can see that this is a very PSMA avid tumor in the transition zone. And it really is, there were no, it was non-mucinous, there was no cribiform pattern. And if we go back and have a look, whenever I see this confluent contrast pattern, my PET MRI learning is to be careful. And what I would say after speaking to Yeli is that don't go off piece, don't always stick to PIRADS, but if you do have concerns that are outside PIRADS, then you should mention them in your report. And unfortunately, this gentleman, 2 months after his surgery, he had negative surgical margins, but his first postoperative PSA was 1, and he had another PSMA PET, and that was negative. So he's presumed to have micrometastatic disease, given he had negative surgical margins just 2 months prior. He may have a tiny bit of tumor at the anastomosis, but presumed micrometastatic disease. And, so this is one of our big PET MRI learnings, is particularly we're missing tumours in the central zones. But if you go back, if there is very confluent restricted diffusion, and if there is that very confluent contrast and enhancement pattern, and we found also not in the central zone, but in that anterior paramedian transition zone, particularly when it's very geographic and asymmetric, then to be worried, particularly if it's not strictly PIRADS, and to mention this in your report, because PSMA also reflects vascularity. So you can almost use your DCE like a pseudo PSMA PET, and go back and look through it in stack mode and look at it come in and wash out and look for asymmetry. And I think you'll pick up some MRI occult tumours, but don't go off piece, stick to your PIRADS. But we're finding that transition and central zone tumours, and also tumours at that extreme base central zone, extreme apexes where we're missing them. This is the controversial part, and I know this is, but we actually, in a lot of our men who go on active surveillance, we do a PSMA PET, and we fuse it with the MRI, and we go back and see whether we think there was adequate sampling. Because you know, if all three things line up, if it's not PSMA avid, you haven't got high-grade disease, or you've got favourable 3+4, and your MRI looks reasonably normal, then you can rest assured. But when the PSMA comes back very PSMA avid, you need to really be worried that you might not have accurately sampled that lesion. So we found it very, very helpful. And I think if PSA continues to rise on active surveillance, we do it at the beginning, but I think if PSA continues to rise on active surveillance, and particularly if the MRI is normal, then to go back and do a PSMA PET MRI sooner rather than later. And of the patients we see fail, I've gone back and I've looked at their MRIs over the years, and most of them haven't truly failed. The tumour hasn't been adequately sampled to begin with. And these are these central zone, and particularly these anterior transition zone tumours. And often they're undercalled or not called on MRI. We know that there can be difficult sampling of the anterior transition zonal truss. We get pubic bone interference. And there's also, we know that some, PIRADS 5 lesions can come back as Gleason 6. So there's also a bit of acceptance bias when you think, oh, it's PIRADS 5, only got 3+3. You think, well, it could be, because we know that these anterior transition zone 3+3s can look worse than they are. So I think that's just a really nice case that shows how we're using PET MRI, and we do PET MRI in every patient we see. And I'm not saying to do it prospectively, but once they've had their MRI and had their biopsy, they then have their PSMA PET. We don't do bone scan anymore at all. Yep. And then we go back and we retrospectively fuse, and we have another look. We have a second look, and we say, hey, there's MRI occult, central zone, basal tumor extension. Be very careful, you might get a positive margin. And we've identified a lot of that actually. So a little bit controversial, but we found it very helpful.
To be controversial, yeah. Lisa, and absolutely cutting edge sort of stuff in terms of imaging. PET MRI, Mark, what do you think?
No, we were also very lucky and have got access to it. It's a bit more expensive, so but we can do it on the NHS and privately, and increasingly doing it on first-time diagnosis. Certainly on rising PSA following treatment, MR and PSMA PET. We think contrast is really important, even though the literature doesn't support that. I think because contrast is usually done badly. It's the hardest one to do well and to quality control. And obviously, we're just about to start the trial of biparametric versus triparametric. So, multi-center prospective, which Vero is leading. Yep. No, I mean, I suppose my question would be, when you do a PSMA PET in these low-risk patients, you get quite a lot of false positives elsewhere, and also you get kind of low avidity, indeterminate signal from the prostate in many patients, and it's just quite difficult. This is obviously an easy case as a barn door signal, but in many, I'm chasing. I did one the other day on a low risk patient, and I'm chasing a thyroid lesion now and a T10 lesion in him, which is requiring a CT scan and ultrasound. So it's just that, and then how you interpret the indeterminate result.
Mark, I find that fusing with the MR really helps. You think you can cognitively fuse, but it's difficult. And I think when you do fuse them, those grey areas or the physiologic normal PSMA uptake in the central zones and PSMA excretion in the urethra, all those things become very, very easy to identify. And I think that the subtleties, I find it much easier having them overlaid. Yeah.
Now, guys, I'm very mindful of the time. We've actually gone way over time. I'm massively appreciative.
One thing about colour. I think it's fantastic. I can't live without it. And I think if you have a focal enhancing lesion in the peripheral zone, not the central zone or the transit zone, in the peripheral zone, and the rest of the scan is normal, I'll call that a pyrase 3, and I say to the doctor, you should biopsy that. I think that's a very important take-home point. It's not just the peripheral zone; it's very important.
Valeria.
May I ask to Lisa a question, please? Lisa, sorry, thank you for the case. So my question is, what about the peripheral zone histopathology, histology? Was peripheral zone negative? Because if you give a look to the MRI, at 5 o'clock, you can see a focal restriction.
I will go back. I'll go back to the MR.
On MRI, high B value MRI, middle base left peripheral zone.
Yeah.
5 o'clock. More or less.
Left side, yeah.
Okay. What about on histopathology? From
nothing. The tumor. Yeah, no, the tumor perfectly matched the PSMA PET MRI. On histopath, yeah. And I even made them go back and have a look and look for mucin, look for, cribriform, look for everything because I couldn't understand why I couldn't see it on MRI, and they couldn't answer it.
We published on 200 patients comparing PSMA PET to MR on primary diagnosis, and they come out about the same. There's not that many missed by either. They're probably both about 94% or thereabouts, but they do miss different things, I think. Yep.
They're complementary. Now, I am going to have to wind us up, everybody, because we've gone over time. Just a final message to everybody who's attending. This webinar is not to discourage you from using prostate MRI, even though we've had some very tricky cases. That was very deliberate. MRI is, part of the workup now for prostate cancer diagnosis. It's in the EAU guidelines, so it should be used. But it is, I guess, to encourage people to really get involved with education and training in prostate MRI, so that you can minimise the risks of misreading them, whether it's overcalling or undercalling. So with that, I'd like to thank all our illustrious panelists. Valeria, Mark, Lisa, Richard and Andrew, thank you so much for giving your time on a Saturday. It's greatly appreciated. Thank you to everybody who has joined this webinar today. We will be getting in touch with all the attendees to follow up, and please provide us with feedback. We'd love to hear what works for you, what doesn't work, what you'd like to see in the future. And yeah, thank you again to everybody, and we do hope you found it useful. And good night.
Thank you.